Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Servia.
Hello, I'm Eric Solman, the chair of the Department of Radiation Oncology at the Duke University School of Medicine in Durham, North Carolina, the United States. I'm going to talk about a program titled Highlights from San Francisco 2025, The Evolving Role of Radiation Oncology in Lower-Grade Glioma Care. In this program, I will summarize key clinical information presented by myself as well as my colleagues in this program, who include Dr. Mitchell Berger from the Department of Neurosurgery at the University of California, San Francisco, Dr. Benjamin Ellingson from the Department of Radiology at the University of California, Los Angeles, Dr. Leah Hallis from the Department of Radiation Oncology at the University of Washington, Fred Hutchinson Cancer Center, and Dr. Michel Weller from the University of Zurich, Department of Neurology. This symposium was held concurrently at ASTRO 2025. If you would like additional resources, please see the accompanying audio and slide deck from the full symposium on the right-hand side of the page. So today, I'm going to highlight advances in the treatment of IDH mutant gliomas from the perspective of the radiation oncologist, and discuss how we in radiation oncology can navigate and work with novel therapies as they become available in this clinical context. So for some background, we have decades of experience using radiation and cytotoxic therapies, particularly chemotherapies like PCV and temozolomide-based chemotherapies. We have level 1 randomized data that supports multimodality therapy with improvements in the overall survival of patients. Prior to the development of inhibitors of mutant IDH, treatment decisions were still controversial. There was often debate in multidisciplinary settings about observation versus upfront therapy versus using cytotoxic therapies as salvage. And these debates centered on combinations of clinical and pathologic factors. Most of the data we used to drive clinical decision-making was based on the pre-IDH mutation data that was available at the time. Now, molecular pathology has evolved very quickly and sometimes more rapidly than clinical trials can keep up. New targeted therapy with IDH inhibitors really represents the first FDA-approved based therapy for targeted therapy in gliomas. And the data for it is based on progression-free survival data. So many questions remain today. Who do we select for IDH inhibitor therapy? When is it appropriate to deliver upfront cytotoxic therapies like radiation and chemotherapy? What is the best therapy to use when the patient experiences tumor progression as salvage therapy? What is the best combination of therapy, given all the choices available today? Ultimately, what practical criteria can we use to help make decisions in real time while participating in a multidisciplinary conference? So Dr. Michel Weller did a wonderful job reviewing the pathology and clinical data on this patient population of IDH mutant gliomas. So the World Health Organization revised criteria for classifying brain tumors in 2021. And the key differentiating factor in gliomas is the presence or absence of the IDH or isocitrate dehydrogenase mutation. Those tumors that are IDH mutant are then subcategorized into whether or not they have a combined deletion of chromosomes 1p and 19q, or whether 1P or 19Q is intact. If it is not intact, the tumor is classified as an oligodendroglioma, and if it is intact, it is classified as an astrocytoma. Some of the astrocytomas have an additional genetic alteration of CDK N2A and B, and this leads to diagnosis of a higher grade astrocytoma, a grade 4 astrocytoma. What we're not going to talk about today are those tumors that are IDH wild type. Those tumors are characterized as glioblastoma or other types of high-grade glioma. So IDH mutation, which can occur in either the IDH1 or IDH2 gene, leads to a metabolic change in the cells. Cells will have both a normal copy of IDH as well as the mutant copy of IDH, and it's the mutant copy that will lead to accumulation of an oncometabolite called 2-hydroxyglutarate or 2-HG. The presence of a buildup of 2-HG leads to many effects in the cell, including epigenetic dysregulation, prevention of differentiation, potential impacts on self-renewal or stem cell properties, upregulation of various oncogenic pathways like the PI3 kinase mTOR pathway. It may have effects on immunosuppression in the microenvironment of the gliomas, and it can lead to disturbances in DNA repair, with at least one report talking about a homologous recombination-like defect. IDH mutated astrocytomas are graded according to World Health Classification criteria, and without getting into too many details, are largely based on the presence or absence of abundant mitoses. This is a very subjective grading, and indeed, the difference between a grade 2 and a grade 3 tumor is often very subjective. The current WHO grading system does show some differences in survival based on grade, despite the subjectivity. But one of the more important criteria, as mentioned, is in the higher grade is the presence of the CDKN2A deletion. How IDH mutant gliomas are treated is, as I said, controversial. These are guidelines that were put forth by the European Association of Neuro-Oncology, and we will get into greater detail about how these guidelines can be used in a multidisciplinary setting. Most importantly was a clinical trial, the first clinical trial in a randomized setting that used an IDH inhibitor. This was a trial called the Indigo trial. It used the drug vorasidenib and included patients with grade 2 tumors that were IDH mutated. They could be either oligodendroglioma or astrocytoma, based on guidelines that preceded the World Health Organization 2021 guidelines. And patients had to have some measurable amount of non-enhancing disease, and they did not have, as the clinician perceived it, an immediate need for chemotherapy or radiation at that time. Patients were randomized to drug or placebo, and the primary endpoint was progression-free survival. The results of this trial showed a significant improvement in progression-free survival for patients receiving vorasidenib. And as you can see, this was independent of other clinical and pathologic factors. Of note, patients that progressed on this trial were able to then receive vorasidenib in a crossover format. And so as a result, it will not be possible to determine the overall survival benefit of vorasidenib given the crossover, with the exception of comparing it to upfront versus salvage vorasidenib. Overall safety on the Indigo trial showed that it was well tolerated. However, there was some increase in liver enzymes and mild increase in seizure activity in the treated arm. So the question remains, how does this fit into any of the guidelines that have been made to date, including these European Association of Neuro-Oncology guidelines that Dr. Veller discussed? In August of 2024, based on the Indigo trial, the FDA approved the use of vorasidenib for all patients greater than or equal to age 12 with grade 2 astrocytoma or oligodendroglioma and a demonstrated IDH mutation. It did not matter how much tumor was remaining after initial surgery, so the FDA approval included gross total as well as subtotally resected cases. Of note, the European Medical Association has more recently approved the use of vorasidenib just prior to this symposium. An important discussion about the use of vorasidenib was recently published and brought up questions about progression-free survival endpoints in comparison to prior overall survival endpoints, and whether the patients in this trial are really represented by the ultimate approval for this trial. And so there are many questions that remain. In clinical practice, many centers use this algorithm, again, focusing on initial surgery, which is really geared towards a maximal safe resection. And then if the resection is complete, to observe if there is residual disease, but deemed not to require initial treatment with radiation or chemotherapy, the patient is started on vorasidenib, and patients considered high risk are then immediately started on radiation followed by chemotherapy. So now the question remains, what are the approaches that should be done beyond a vorasidenib alone strategy? And so there are many areas of investigation being conducted around the world, combining vorasidenib with radiation and or chemotherapy, use of PARP inhibitors. These drugs have a relevance in the homologous recombination deficient tumors, combinations with immunotherapy and other, including vaccine therapies, and a variety of different trials are being studied. Dr. Hallis discussed how, in greater detail, how gliomas have been treated based on the available clinical trial evidence. When you look at the IDH mutant landscape, based on the overall survival estimates that have been developed from existing clinical trials, you can see that patients with grade 2 tumors show a very long median survival, 20 years for oligodendroglioma and 11 years for astrocytoma. These numbers go down in higher grade as expected, and of course grade 4 astrocytomas have a much lower survival. If we look at the timeline a patient may experience, you can see that historically patients that qualified for upfront treatment, which might have included radiation or chemotherapy, versus those patients that could have gone on close observation or active surveillance, were then followed. And at recurrence, those patients might have gotten resurgery or chemotherapy at that time. Those patients treated initially would have gotten enrollment on a clinical trial or potentially reirradiation or additional chemotherapy, and then continued to be followed. ASTRO published guidelines back in 2022, which Dr. Hallis led, which helped define the strength of evidence for the treatment decisions that have been made. And what you should note is that those evidence that are considered strong are those in which everyone is in agreement, and those that are conditional are in which the majority are in agreement, but that some may be objecting. And what you can see is that for grade 2 tumors that have been subtotally resected, that are co-deleted for 1p and 19q, the use of radiation and chemotherapy was still considered conditional. And for grade 2 astrocytomas that had undergone a gross total resection, the use of close observation or surveillance was considered conditional, as was the case for the use of radiation and chemotherapy. So this suggests there's a lot of discussion, and indeed, most multidisciplinary conferences, it was these patients that would have fallen under the conditional strength categories that underwent the greatest debate. These data, which came from a well-known EORTC trial, 22845, randomized patients to immediate radiotherapy versus delayed or salvage-only radiotherapy, and showed an improvement in progression-free survival but not an improvement in overall survival, suggesting that using radiation as salvage may not impact the overall survival of patients. The RTOG 9802 trial, which really established much of the treatment paradigm used in the pre-IDH era for grade 2 gliomas, divided patients based on an age cutoff and whether there was gross total resection. So patients in a low-risk category, shown by the top Kaplan-Meier curve, were under age 40 and had gross total resection and underwent initial observation. Those that were over 40 or had a subtotal resection were considered high risk. And as you can see, that high-risk group had a range of survivals. So in this trial, the high-risk group patients were given either radiation plus chemotherapy or radiation alone. And after a long follow-up period, it was found that there was a significant improvement in overall survival for patients that got radiation followed by PCB chemotherapy. This then, as you can see in the ASTRO guidelines, really established that patients who have a subtotal resection should be treated with radiation and chemotherapy, though again, there isn't complete consensus on this. The question remains for grade 3 tumors, what to do. And for anaplastic oligodendrogliomas, the so-called CODEL trial, also known as RTOG 9402, is still undergoing analysis. For 1p19q non-deleted tumors, the CATNON trial has been analyzed and shown a benefit to adjuvant chemotherapy following radiation, and some subset analyses looking at IDH tumors may show benefit with concurrent chemotherapy. So as you can see, this led to the strong recommendation of adding chemotherapy to radiation for grade 3 tumors. But as I mentioned before, grade 2 and 3 tumors are not so different and largely based on the presence of mitoses. So this recommendation is still controversial. So now, how do IDH inhibitors fit into this recommendation? And if we look at the data from the INDIGO trial, for patients that had grade 2 tumors with some residual non-enhancing disease, but not considered sufficient to require upfront therapy, in that trial, they had to be within 1 to 5 years of surgery. They would then have been eligible for that trial. There is some data in recurrent tumors using other IDH inhibitors that provide some limited data, though not in a randomized fashion. If we look at the phase 1 trials for IDH inhibitors, you can see the proportion of tumors that came from grade 2 as well as those that had prior treatment. One key differentiating factor in what was found to be the responsive tumors was the presence or absence of enhancement. And so there is a significant difference in response in the patients that had non-enhancing tumor, much longer progression-free survival compared to those that had enhancing tumor. And as a result, for the most part, the use of IDH inhibitors has been limited to patients with non-enhancing tumor. So there are many questions that remain about IDH inhibitors and their use in this patient population. And I've stated many of them so far, but clearly it's unknown to what extent they can be used in patients with enhancing disease, what is the optimal timing, and what are the optimal combinations. There are many trials that are combining IDH inhibitors with other drugs, including temozolomide, pembrolizumab, and sequencing IDH inhibitors at different times with chemoradiation. Other IDH inhibitors, in addition to vorasidenib, are also being investigated in various clinical contexts. So when we think about treating patients with upfront radiation versus observation, there are many things to consider. How fast is the tumor growing? How much residual disease is there that might impact the radiation treatment portal, or how much normal brain will be treated if we treat upfront versus treating in a delayed setting or salvage setting? One might think that avoiding treatment might have a benefit in terms of avoiding or delaying any normal brain toxicity. But it's important to note that not all tumors grow in a linear fashion, and some tumors may grow very quickly and unexpectedly over a short period of time. So if a patient is being surveilled, it's important to watch very closely. It's also important to note that on the Indigo trial, though there was a overall decrease in tumor volume over treatment time in the patients that received drug, it is also the case that even within those groups, there was quite a lot of variability. And you can see from the red dots that some of the patients indeed did grow on treatment, though overall the population did decrease in size. It's commonly stated that by deferring radiation, one is deferring the potential cognitive consequences of radiation therapy to the brain. It is interesting to note that the use of modern radiation may not result in as much cognitive decline or any significant cognitive decline, whereas the presence of tumor itself can lead to neurocognitive decline. This is an interesting study where they looked at untreated patients and what was the impact of tumor on cognition using a standard battery of neurocognitive tests. And as you can see, the tumor itself leads to cognitive impact. And so delaying treatment itself is always a balancing act. In this prospective study using modern radiotherapy, they looked at neurocognitive function over time. And what they found is, regardless of treatment, there wasn't really a significant change in cognition. And so the concept that radiation to the brain will definitely cause neurocognitive decline may not be the case in the era of modern radiotherapy. All of this leads to, again, the emphasis on the need for a multidisciplinary discussion and a need for the radiation oncologist to enter that discussion knowing all of the data that is present, both on the effects of radiation and on the benefits of the various treatments and the timing that we know about to date. The current ASCO and SNO guidelines recommend the use of vorasidenib in grade 2 gliomas when it is deemed acceptable to delay the use of radiation and chemotherapy. The next speaker in the symposium, Dr. Ellingson, provided significant information about the use of advanced imaging in the decision-making that is required on when to give IDH inhibitors. Current guidelines for advanced imaging are shown here and include standard 3D or volumetric scans in T1 and T2 flare, pre and post contrast, and include volumetric scans with T1 pre and post contrast and T2 flare protocols, and also recommended diffusion weighted imaging. Dr. Ellingson provided extensive detail, and I referred to the accompanying slides to this symposium, showing how, though these studies are critical in evaluating patients, they have certain limitations, and some other advanced imaging may provide additional details about what is true progression, for example, over treatment effect. Some of the more interesting approaches to analyzing the presence or absence of tumor are the use of amino acid PET, and a variety of technologies have been developed to look at this. And again, I will refer you to the slides for some of the emerging approaches for this that are currently being used. I'll just summarize the imaging discussion from Dr. Ellingson to say that current anatomic-based MR imaging remains the cornerstone of disease monitoring in IDH mutant tumors. However, it does suffer some limitations, and there are some advanced MR techniques such as perfusion MR, which offer some potential benefits when combined with anatomic imaging, and amino acid-based PET imaging may provide even additional information as it becomes more widely adopted. The remainder of the symposium was focused on a discussion among the experts at the symposium regarding a couple of multidisciplinary conference-like cases. I'll briefly summarize these cases. The first case involved a 38-year-old patient who presented with focal seizures that were controlled with anticonvulsant therapies for the most part, but the patient did have some mild expressive aphasia. The initial anatomic imaging of this patient identified a near 6 centimeter hyperintense in T2 flare lesion in the left frontal temporal lobe with no enhancing tumor. The patient underwent a resection, what was deemed at the time a maximal safe resection, and there was some significant material left behind. Though the patient didn't have any new neurologic deficits from the surgery, the important thing was that there were some persistent neurologic deficits, particularly the aphasia. Pathologically, this was an IDH mutant astrocytoma, as verified by the intact 1p19q. The key points of discussion on this case by our experts was, one, the persistence of neurologic symptoms, and also the persistence of tumor after surgery. There was general consensus that based on these factors, this would be a patient that would benefit from upfront radiation and chemotherapy. There is some debate as to which chemotherapy to use based on the difference between an oligodendroglioma and an astrocytoma, and in this case, as an astrocytoma, the chemotherapy would most likely be temozolomide chemotherapy. An important note in this case was that the persistence of residual tumor in a multidisciplinary setting might bring up the discussion of whether additional surgery might be beneficial. Dr. Berger brought up that tertiary centers may have the ability to do more aggressive surgeries or more complete surgeries and may be a potential referral for patients with significant residual tumor. Because the ability to remove this tumor may change the ultimate treatment decision by the multidisciplinary tumor board. A second case was presented about a 42-year-old woman who also presented with seizures that were also partially controlled with anticonvulsant therapy. This patient presented with some very mild neurologic symptoms, particularly word-finding difficulty, but overall had a performance status that was better than the previous patient, essentially a ECOG PS of 0. This patient had a T2 flare hyperintense lesion of the right frontal lobe, measuring about 4 centimeters. In the discussion about the surgical resection of this case, Dr. Berger brought up the importance of maximal safe resections, particularly in the context of supratentorial lesions. He noted that there was an increase in overall survival based on the extent of resection in these cases. Indeed, the amount of residual tumor correlated well in multiple data sets to overall survival. Dr. Berger also highlighted that advanced surgical techniques have been developed to improve the extent of resection, including the use of aminolevulonic acid staining or stimulated Raman spectroscopy for intraoperative histology. In the case that was presented, the patient underwent surgical resection. This is the post-operative MRI, and Dr. Berger noted that there was some residual disease present that a re-resection may be able to resect. The pathology of the initial resection again showed an IDH mutant tumor, and again, chromosomes 1p and 19q were intact, indicative of an astrocytoma. In this patient, with little, if any, residual tumor, particularly with the potential of a second resection, the suggestion was potentially for the use of either observation, if that tumor was small enough and showed no evidence of progression, or treatment with an IDH inhibitor, until at such time there was evidence of progression, in which case radiation or chemotherapy could be used as salvage. There was considerable discussion, however, about the use of IDH inhibitors, and one which is important to note that in a person of childbearing age, in this case, this 42-year-old female, that if she were on vorasidenib and wanted to become pregnant, she would have to stop treatment as vorasidenib is contraindicated in pregnancy. There was also discussion regarding the amount of tumor volume that remained and whether this would require significant radiation dose, given that it was very small and may be very simple to treat with modern radiation. Nevertheless, it was deemed a reasonable approach to give vorasidenib up front should there be evidence or concern about progression of residual tumor in this context. It was also mentioned that advanced imaging might be helpful in evaluating the residual tumor, and even the use of amino acid PET-based imaging might be most helpful. So I think what we take from this symposium is that there's a critical need for the radiation oncologist to both be present in the multidisciplinary context and really be an expert on the information and the data that support the use of radiation, when it should be used, and an understanding of when it might be appropriate to look for other upfront therapies, including IDH inhibitors, additional surgical resection, or chemotherapy. It's also important to advocate for advanced imaging when it's unclear whether there is residual or progressive tumor present. And as the radiation oncologist, we have a unique role to play. We understand the long-term data, we understand the imaging, and so we can really provide leadership in a multidisciplinary context to help guide the care of these patients. Thank you very much.